Hello friends, welcome to Essential Med Shots. Today we are learning about drugs for peptic ulcer disease. Peptic ulcer disease is an imbalance between aggressive factors and defensive factors. Which are the aggressive factors? Gastric acid, pepsin, H. pylori infection and NSAIDs. Defensive factors are gastric mucus, bicarbonate, and prostaglandins. Pharmacotherapy aims to reduce acid secretion, neutralize existing acid, or protect the mucosa. Classification of anti-ulcer drugs: reduction of gastric acid secretion through PPIs, H2 receptor antagonist, anticholinergics, and prostaglandin analogs. Proton pump inhibitors: omeprazole, pantoprazole, rabeprazole, esomeprazole. H2 receptor antagonist: ranitidine, famotidine, cimetidine. Anticholinergic: pyrazapine, rarely used now. Prostaglandin analogs: misoprostol. Neutralization of gastric acid, also known as antacids. Systemic and non-systemic. Systemic: sodium bicarbonate, sodium citrate. Non-systemic: magnesium hydroxide, aluminum hydroxide, and calcium carbonate. Ulcer protectives: sucralfate, colloidal bismuth subcitrate, CBS. Anti-H. pylori drugs are the antimicrobial drugs: amoxicillin, clarithromycin, metronidazole, and tetracycline. Proton pump inhibitors. Proton pump inhibitors are the most efficacious inhibitor of gastric acid secretion and are the drugs of choice for almost all acid peptic disorder. Mechanism of action: PPIs are administered as inactive products, usually enteric coated, to prevent premature destruction in the stomach. They are absorbed in the intestine, reach the parietal cell via bloodstream, diffuse into highly acidic secretory canaliculi of parietal cell. In this acidic environment, pH less than 2, they are protonated and trapped. They undergo molecular rearrangement to form active sulfonamide derivatives. The sulfonamide covalently binds to sulfhydryl groups of the proton pump. This causes irreversible inhibition of the final step of acid secretion. Acid production only resumes when new enzyme molecules are synthesized, which takes 18 to 24 hours, which gives the proton pump inhibitors a long duration of action despite a short plasma half-life. Therapeutic uses: peptic ulcer diseases, gastric and duodenal, rapid healing of ulcers. GERD, gastroesophageal reflux disease, first-line therapy. Zollinger-Ellison syndrome, high-dose PPIs control the massive acid hypersecretion from the gastrinomas. NSAID-induced ulcers, for both treatment and prophylaxis. H. pylori eradication, part of the triple and quadruple regimen. Adverse effects: short term, nausea, loose stool, and headache. Long term, hypochlorhydria, leads to decreased absorption of vitamin B12, iron, and calcium. Decreased absorption of calcium leading to increased risk of osteoporotic fractures. Increased risk of enteric infection, respiratory infection. Hypomagnesemia can also occur. H2 receptor antagonist. Drugs like ranitidine, famotidine competitively block H2 receptor on the parietal cells. They are highly effective at inhibiting basal and nocturnal acid secretion, but are less effective than proton pump inhibitors at blocking male stimulated secretion. Ranitidine has largely replaced cimetidine because it is more potent, longer acting, and does not possess anti-androgenic side effects like gynecomastia, impotence, or the massive cytochrome P450 inhibitory effects of cimetidine. Uses: mild to moderate GERD, maintenance therapy for peptic ulcer, stress ulcer prophylaxis. Antacids. Antacids are the weak bases that chemically neutralize gastric acid to form salt and water. They do not decrease acid production but raise the gastric pH. Raising the pH greater than 4 also inactivates the proteolytic enzyme pepsin. systemic antacid and non-systemic antacid. Systemic antacids, for example sodium bicarbonate, are the water soluble, acts instantly but are absorbed systematically, can cause systemic alkalosis and sodium overload. Sodium overload is dangerous in the congestive heart failure and hypertension. Rebound acidity and massive CO2 production limit their use. Non-systemic antacids, which are poorly absorbed. First is aluminum hydroxide. Slow acting, strong astringent properties, causes constipation, form insoluble complexes with dietary phosphate causing hypophosphatemia. Magnesium hydroxide, fast acting, draws water into the gut causing a osmotic diarrhea. Megalodrate antacid combination. Why we are using antacid combination during pharmacotherapy? Because aluminum causes constipation and magnesium causes diarrhea. They are invariably combined in commercial preparation to cancel out each other's bowel side effects. Thank you.